I want to welcome Ramiro Mitre, who is a dear friend and colleague. And so he is going to be talking with us today about neuroaffirming practices. So the title of the talk is Neuroaffirming Practices, Autism, Neurodiversity or Neurodivergence, and the Myth of Normality. And certainly when I think about neurodiversity and when I think about the paradigm shifts and the ways that we can address ensuring that people like we just heard from are included in all of our spaces, this is going to be in a very important talk. We're going to be talking about understanding the neurologic differences as the natural human variation rather than deficits. We'll also be thinking about defining the principles of neuroaffirming practices, clarifying terminology, and really helping to emphasize the role that we as professionals, as well as people who love autistic people or who are autistic, can shape the experiences of autonomy, authenticity, and inclusion. So for the next 45 minutes, Ramiro will talk about neuroaffirming practices, autism, neurodivergence, and the myth of normality. So over to you, Ramiro. Super excited to hear from you.
Thank you so much, Christine. Can we skip my talk and keep listening to the panel? What a great conversation. Hello, everyone. First of all, thank you all for being here. And of course, thank you to the Autism team for creating spaces like this. It is a real pleasure to collaborate with this amazing group, and honestly, a privilege to be part of conversations that are thoughtful, that are open and accessible to professionals from many different places. I want to start by going back to the beginning of my career. As many of you, I was trained in a very traditional model, a model that focused strongly on normalization, and I suspect many of you were also trained in something similar. The goals were very clear: to reduce symptoms, to increase functional skills, to help the person move closer to what we define as adaptive or typical behavior. And at that time, that framework made sense to me. It was structured, it was measurable, it was responsible, or it felt responsible. So when you're starting your career as a clinician, that kind of structure can feel reassuring. You feel like you know what you are supposed to do, but even then, something felt a little incomplete, I think is a word. I wouldn't say I disagreed with what I was taught, but it was more a sense that there were questions that we were not asking. Part of that context is really, really important because in Argentina, from where I am from, and in many other parts of the world, access to evidence-based practice has historically been limited. Training opportunities were scarce. They are still scarce today, I would say, and many professionals are trying to do good work with very few resources and very little access to updated training. So part of my journey started with curiosity. And honestly, it also started with privilege because I had the opportunity to train in different models, to travel abroad, to collaborate internationally, and to learn from multiple different perspectives. So, of course, that expanded my clinical understanding, but what truly transformed the way I think about autism were not the models or the theory. It was autistic people themselves, listening to their experiences, hearing how interventions felt from their side, watching families navigate systems that were trying to fix their children instead of understanding them. And on a very personal level, living with my autistic sibling as well, that taught me a lot. He's an adult and he requires significant support in daily life. Sharing a home with him has totally changed the way I understand autonomy, dignity, support, and difference. Because when autism is part of your everyday life, you start noticing things that theory alone does not teach you. You start noticing how systems interact with people, how environments create different barriers that we don't always see. Support is not just about skills, it should be also about context and relationships and dignity. And over the time, I realized about something very important. The question is not only how do we intervene, I think the deeper question is more what assumptions are guiding the way that we intervene. And that question is really the starting point for everything that we are going to explore today. There will be many more questions. Because when we talk about questioning assumptions, I am not talking about rejecting science. I'm talking about expanding it. Most of us, again, were trained to focus on observable behavior, And that makes a lot of sense. Observable behavior is measurable. It allows us to track progress. It gives us structure, and it makes our work feel structured. And there's real value in that. But observable does not always mean meaningful. We can measure reduction of behaviors. We can measure skill acquisition. We can measure how often a child responds to an instruction. Those are things that are pretty easy to quantify, but there are other questions that are a little harder to measure. Do we measure autonomy? Do we measure how much effort someone is investing just to appear typical? Do we measure stress? Do we measure the long-term cost of constantly having to adapt to environments that were not designed with you in mind? That's, can we just walk in those shoes for just 2 minutes and see and try to guess what it feels like? So, for example, a child might learn to maintain eye contact during a session. This was very beautifully mentioned in the previous panel. And that might look like progress in a data sheet. But we rarely ask what that effort costs the person. Are they concentrating on the conversation, or are they concentrating on remembering to look at someone's eyes? Because those are very different experiences. So if we want to enrich our practice, it doesn't mean necessarily abandon what we already know. It just means that we might want to keep what works while we are willing to examine the parts of our practice that we inherited without questioning. Because science grows that way, not by defending what we already know, but asking better questions. Before we talk about neurodiversity, and Christine mentioned this a little bit earlier, I think it's helpful to name two frameworks that are often the shape of how we understand disability. The first one is the medical model, and in that model, the focus is mainly on the individual. The question here tends to be what is impaired, what is delayed, what needs to be treated or improved. And that perspective has shaped a lot of clinical training, and in many ways it makes sense. Medicine is designed to identify problems and address them, but the social model approaches things from a different angle. Instead of starting with the individual, it asks what barriers are present in the environment. How do systems, how do expectations, how does structure turn difference into disability? And I want to be careful here. This is not about saying medical bad, social good. Most of us work in the real world where both perspectives appear every day. So clinical needs are real, support needs are real, but the lens we use still matters because the model we rely on influences what we notice, what we prioritize, and even what we call success. For example, imagine a student who struggles to sit still during a long class. From one perspective, the question might be, how do we increase compliance with classroom expectations? From another perspective, the question might be, what about this environment is making sustained sitting so difficult? Same student, different questions, very different types of solutions. So as we move through this talk, I'm not asking everyone to abandon clinical thinking. I'm simply inviting you to notice the underlying thinking that is shaping the goals that we set. Because sometimes we don't consciously choose the framework. We simply inherit ways of thinking that sometimes feel obvious. And we seldom pause to examine them. So this is an invitation to do so today. If we say we inherit certain ways of thinking, one of the most powerful and I think least questioned is the idea of normal. We use that word all the time in reports, in classrooms, in therapy sessions, and most of the time we don't even notice it. But the word normal did not originally mean what we often assume today. It began more as a statistical concept. It just described the average within a population. But over time, that statistical idea slowly started changing the meaning. First, it became a clinical benchmark. Then little by little, it became an expectation. And this is where I think we need to slow down for a moment. Because when normal becomes the goal, something subtle starts to happen. Difference quietly becomes the problem, and not because professionals intend harm, but because the system begins to assume that there is one correct way to communicate, one correct way to regulate, one correct way to socialize or even to learn. And when that assumption becomes invisible, it starts shaping our goals without us realizing it. Sometimes I ask myself a simple question, and I invite you to ask it as well. When we say we want someone to be more functional, what do we actually mean? Are we thinking about a person's autonomy, or are we thinking about how comfortable other people feel around them? The question is not meant to accuse anyone, it is just meant to help us reflect, because the myth of normality is not that difference exists. The myth is that there is only one acceptable version of being human. And once we begin to question that assumption, many other conversations start to become possible. So if normality is a rather narrow standard, the obvious question, I think, is what is the alternative, right? One way of thinking about that alternative is the concept of neurodiversity, one term that I really love. But some people might think this is a trend. It is not. It's not a trend. It's not a slogan. It's just the recognition that neurological differences are part of natural human variation. Brains do not work in the same way. People process information differently. People communicate differently. They regulate differently. They learn differently. So variation is part of how our species work. Sometimes I use a very simple comparison. Human beings vary in height, in body type, in skin color, in temperament. Neurology is part of that variation too. Some people process sensory information differently, some regulate attention differently, some communicate in ways that don't always match the social expectations. Neurodiversity simply recognizes that these differences are part of the range of human development. And of course, recognizing variation does not mean ignoring challenges. It does not mean that we have to pretend support needs do not exist. My siblings, for instance, he has significant support needs. That reality does not disappear just because we use the word diversity. What changes is not the reality. What changes is the starting point. Instead of beginning with the question, how do we eliminate differences? How do we change this person? We should begin with a different one. How do we support this person in building a life that works for them? And that shift may sound subtle, but in practice, it changes everything. It changes how we write goals, it changes how we speak to families, it changes how we interpret behavior, or even how we define progress. And when those small decisions start to change, little by little, the whole direction of intervention begins to shift. Now, I want to clarify something that often creates confusion. When we talk about neurodiversity, we are actually referring to three different things. First, it is a concept, a descriptive term that recognizes natural neurological variations across human beings. Different brains develop and function in different ways, and that variation is part of the human population. Second, it's a movement, a civil rights movement. It's led largely by autistic people themselves, advocating for dignity, for access, and social participation. And third, it is also a paradigm, a broader shift in how we understand difference and how we understand disability, how we understand support. Each of these layers could easily be a full conference on their own. So, of course, today we are oversimplifying things, but I think the distinction matters because sometimes people criticize the movement when the conversation is actually about the paradigm, or they reduce the paradigm to a debate about terminology. And those are not the same things. Of course, they are all very important, but for our purposes today, I am mainly speaking from the paradigm level. In other words, the lens that shapes how we interpret what we see in clinics, in schools, and in families. So when we talk about neurodiversity, we are talking about variation across human beings, and neurodiversity is a characteristic of our species. It's a description on the fact that there is natural cognitive variation among people. So in that sense, humanity itself is neurodiverse. Sometimes we hear people say, this person is neurodiverse, that person is neurodiverse, but it is a bit like saying this person is diverse. It's, it doesn't quite make sense because diversity just describes variation within a group, and it's not a property of a single individual. Within diversity, individuals may be neurotypical, meaning their cognitive style aligns more closely with dominant social expectations. And here I'm going to have to agree with the panel before, and I think we should come up with different terms because this is very you and us, and it creates differences. But for the purposes of understanding different ways of developing or different ways of how the brain works, we are still keeping that separation. We can also have neurodivergent people, meaning that their cognitive style is a little divergent. It diverges from the typical expectations. And I think what matters here is that these are only descriptive terms. They describe a relationship to a norm, but they should never be judgments. They are not rankings. They just are a description of variation. And once we separate variation from value, the conversation becomes way more productive because we are no longer debating whether difference should exist. We can start focusing on the real question, which I think is, how do we support people within that variation? So once we understand neurodiversity as variation, the next question is, I think, more practical. What does that mean for how we actually work? So how does this translate into what I do in my everyday life? Well, neuroaffirming practice is not a technique, it is not a protocol, and it is certainly not a specific therapy model. I think the best way to understand it is as a stance, a professional stance that's grounded in respect for identity, for autonomy, and for lived experience. And what that stance really changes is the starting point. Instead of beginning with the question, how do we make this person more typical? We begin with a different question. How do we support this person in ways that preserve dignity and reduce harm? And at first, the shift, again, this shift might sound subtle, but in practice, it's not. It affects the decisions that we make. It influences how we write goals, again, how we interpret behaviors, how we collaborate with families, and it even influences the emotional atmosphere of the intervention. And sometimes it changes something even deeper. Who holds the power in the room? Now, I've been told more than once that this perspective risks romanticizing autism, but there is a very important difference between a neuroaffirming approach and denying real challenges. Neuroaffirming practice does not ignore support needs. On the contrary, it takes them seriously. It simply begins from the person's strengths and identity while supporting them in navigating those challenges. My sibling, for example, he still requires significant daily support, and that reality does not disappear. It will not disappear. What changes is how we understand that. Support is no longer about correcting who he is. It's about helping him build a life that works for him, and that could take so many different shapes. If we say that neuroaffirming practice is a stance, then that stance needs to be more visible. Over the time, many authors, activists, and even clinicians have described a set of principles that help guide this way of working. They, of course, draw from the neurodiversity movement, but it also stands the ground on the disability studies and in clinical practice. And of course, they are not rigid rules. They are not checklists. It's not a list of things that we can follow. But I like to think of them more as orientation points, small beacons that help guide the decisions that we make in practice. Each of these principles could easily take an entire lecture on its own. So again, we'll just move through them briefly. But before we do, I want to say something clearly. If at any point you feel uncomfortable while we talk about these ideas, it doesn't mean that you're doing something wrong. It probably just means that you are noticing something. And honestly, that's exactly the point. Well, I should clarify. I'm not trying to make anyone uncomfortable. What I'm hoping for is something simpler, that we look at some familiar practices from a slightly different angle. And this is not about blaming anyone. None of us chose the systems that we were trained in. So, of course, we absorbed the assumptions. And that is exactly how training works, right? But once we start reflecting more critically on our roles, we gain something more valuable. We gain the ability to decide which assumptions we want to keep and which ones we may want to reconsider. So the first principle is intersectionality. And I know that word can sound a little abstract, but let's make it simple. No autistic person is just autistic. People also have a gender, people also have a culture, a language, an economic reality, a country that shapes what services exist or don't exist. And that context matters because it's not the same to be autistic in Argentina, in the US, or in the Philippines, or even in the same country. A large city is certainly not the same as a rural town. Access to diagnosis, access to therapy, levels of stigma, educational systems, family expectations, all of these can vary dramatically depending on where someone lives. Two people may share the same diagnosis, but they may not share the same barriers, and they may not have access to the same opportunities. When we ignore those intersections, we risk oversimplifying both identity and support. Neuroaffirming practice invites us to widen the lens, not only asking what does this person need, but also asking what systems are shaping this person's experience. Because when context is ignored, we may overlook barriers that are not located in the individual, but in the system around them. And the person continues facing those barriers, often struggling with them, while we may not even realize they are there. Respect for autonomy does not depend on age, it does not depend on spoken language, and it does not depend on IQ scores. Autonomy is a basic human principle, and yet in practice, it often becomes conditional. In many settings, autonomy is granted only when someone communicates in expected ways, or behaves in expected ways, or demonstrate a certain level of independence. Part of the reason this happens is why we often confuse autonomy with independence. But they are not the same thing. A person can require daily support and still have preferences, limits, opinions, and agency. Needing support does not eliminate the right to participate in decisions about one's own life. Autonomy is really about participation in decisions that affect the person at whatever level is possible. In practice, that can mean offering choices in accessible ways. It may mean adjusting how we communicate, giving people enough time to process and respond, paying attention to nonverbal signals. Sometimes it also means something more difficult. It means tolerating moments when the person's preference does not fully align with our plan or our professional expectations. So I think that's it's worthy of our time to ask those questions. Supporting someone should not require overriding who they are. It often requires us to adapt the approach instead. Sometimes autonomy is very clear and very direct. Sometimes it is more subtle and easy to miss. But either way, it's there, and it deserves to be recognized. Presuming competence, and we've heard a great talk that went over competence, and I think it was amazing to listen to, especially coming from an autistic self-advocate. It doesn't mean that we have to assume there are no support needs. It means that we should start from the possibility that the person may understand more than we can immediately observe. In many systems, and especially when communication is limited or unconventional, competence becomes something that must be demonstrated before it is recognized. And that can create a difficult dynamic. When respect depends on proof, the person has very little space to show what they are capable of. So presuming competence simply changes where we begin. We speak directly to the person, we explain what is happening, we avoid talking about them as if they were not present. We also provide access to language, information, and experiences that might otherwise be limited. Sometimes it means giving the person a chance to try something a bit more challenging instead of saying only what already feels comfortable. And of course, we will not always get it exactly right, but consistently understanding someone can quietly close doors. So, and some of those doors are very hard to reopen later. So expecting a little more from time to time tends to carry far fewer risks. The next principle sounds simple, and I am sure that most of us here believe that we validate differences, especially because we work with, live with, or care about people with different kinds of minds. But in practice, it can be uncomfortable because validation does not mean agreement. It means recognizing that the person's experience makes sense from their perspective. Sensory differences are real, processing differences are real, social communication differences are real. When someone avoids eye contact or flap their hand or needs repetition or prefers routine, those are not random behaviors. They are adaptations. Sometimes they help the person regulate, sometimes they help them protect themselves from overwhelm. If our first reaction is to eliminate the difference, we may remove the strategy before we understand the need behind it. So validating difference means slowing down long enough to ask a few important questions. What is this helping the person manage? What might this behavior be doing for them? Not every difference needs to be reduced. Some needs to be understood. And some simply need accommodation. I think validation doesn't mean at all lowering expectation. I think it just means adjusting what we expect and how we support, especially how we support people in reaching it. All of us carry biases. I would like to say that some people don't, or even myself, but that's part of being human. I think the difficult part is that we usually don't see our own biases. And nothing really changes until something becomes visible. One of the most powerful and least visible biases in our field is neuronormativity. Neuronormativity is the assumption that there is one preferred way to think, communicate, regulate, behave, and that moving closer to that standard is that the goal is to always move into that standard. And many of our systems were built around that assumption. Schools reward certain kinds of attention. Clinics reward certain kinds of participation. Workplaces reward certain kinds of communication. Over time, those patterns begin to feel neutral, even natural, but neutrality is often just familiarity. So I think the question here is which expectations are truly necessary for access and safety, and which simply reflect what the majority finds comfortable. Is eye contact always required for connection? Is sitting still always required for learning? Is speaking always required for intelligence? Sometimes norms serve a purpose, but sometimes they simply reflect what makes the majority comfortable. And when we don't examine that, we may unintentionally teach people that being themselves is a problem. Now, rejecting neuronormativity doesn't mean removing expectation. It just means that becoming more intentional, that we need to become more intentional about them. Norms are patterns that we absorb, and expectations are the goals we choose. And those goals deserve reflection because there is a possibility there. Reframing expectations is, I think, the practical continuation of that awareness. When we recognize the bias, the next question should be, what are we actually aiming for? Sometimes expectations are driven by comparison, age norms, developmental charts, peer behavior. Of course, these references can guide us, but they can also narrow our imagination. When expectations are shaped mainly by similarity to others, we may overlook what is meaningful for this particular person. Reframing expectations means asking different questions. What increases quality of life? What expands access? What reduces distress? It shifts the focus from trying to make everyone wear the same shoes to making sure each person can actually walk. The next principle is promoting self-advocacy, and many people in this room live this reality. We just heard the powerful reflections during the lived experience panel, and I'm really glad that conversation was part of this space because those voices really, really, really matter. Self-advocacy is about making space for autistic people to define what a good life means for them. And I think, and I will emphasize the for them, because this is where things can become complicated. Most of us were trained in systems that were shaped by neuronormative assumptions, systems that emphasize measurable progress, observable change, and movement toward what is considered typical functioning. And over time, that tends to shape how we think about success. So when an autistic person defines success differently, a certain tension can appear. That tension usually doesn't come from lack of care. I think it comes from how our professional compass has been calibrated. Self-advocacy is an invitation to pause and to examine that calibration. Is this goal improving this person's life? How do we know? Whose definition of success is guiding the decision? And even more simply, what do we mean when we say success? For some people, success may mean living independently. For others, it may mean having consistent support and stability. For some, it may mean expanding communication. For others, it may mean reducing anxiety or finally feeling understood. Success doesn't follow a single template. It is personal, it is contextual, and it's shaped by lived experience. So recognizing that influence is part of our ethical practice in a way, because a good life cannot be designed entirely from the outside, or it shouldn't. If we are examining our biases and if we are reconsidering how we define success, then I think another question worth asking is, whose knowledge are we prioritizing? In our field, we often talk about evidence-based practice, research evidence, clinical expertise, but lived experience is also a form of knowledge in a very important way, I might say. When autistic adults describe the impact of masking, the exhaustion of constantly adapting, or the long-term effects of feeling misunderstood, that is not an anecdotal noise. It is information about the human cost of certain expectations. If self-advocacy means people have a voice, prioritizing lived experience means that voice actually influences practice. It means allowing those perspectives to inform how we set goals, how we evaluate progress, and how we interpret behavior. Because ethical practice requires more than measurable outcomes. It also requires listening to the people who live with the outcomes of those decisions. I think the next principle is more powerful than it might sound at first. For many autistic people, the first narrative they hear about themselves is deficit-based, delays, impairments, limitations. Even when we are being clinically accurate, the overall message can easily become something about you needs to be corrected. And over time, that message accumulates. So nurturing a positive identity doesn't mean ignoring challenges. Again, I repeat this until I'm tired and until you are tired. It means making sure that difference is not framed as failure. Identity is shaped through repeated experiences, through how adults talk about you, how goals are written, whether your strengths are noticed or taken seriously. If every intervention focuses only on what needs to change, it becomes very difficult for someone to internalize that they already have value as they are. Supporting identity means that we need to be intentional about the narrative that we reinforce. Not only asking what needs work, but also noticing what is meaningful or valuable here. Because long-term well-being is not only on skill acquisition, it is also on self-understanding, self-respect, and the sense that your way of being in the world has a place and it's okay to be who you are. Okay, so biases, expectations, autonomy, lived experience, identity, everything we've discussed so far, it has practical consequences. If we take those ideas seriously, something important follows, and we have to ask where change should begin. For many years, consciously or unconsciously, the answer was the person. But very often, the more effective place to start is the system around them. Adapting systems and environments means shifting part of the responsibility from the individual to the context. It means looking closely at things like sensory load in classroom and clinics, communication demands in therapy sessions, rigid participation rules, evaluation formats that privilege one style of expression. Sometimes relatively small adjustments, lightning, pacing, visual supports, flexibility, it can reduce distress more effectively than repeated skill training. So adapting system doesn't remove challenge. Again, it removes the barriers that were never necessary to begin with. When the environment changes, standards are not lowered. It just becomes more easy to increase access for people. So how can we talk about autonomy or lived experience if we don't fully acknowledge communication? If I ask you what communication means, I'm sure many of you would probably answer talking, and talking can certainly be one form of communication, but it's not the only one. In fact, we can speak a lot and still fail to communicate. Communication can happen through gestures, facial expressions, augmentative and alternative communication, including communication devices, echolalia, movement, even silence can communicate. In many settings, speech quietly becomes the default measure of expression. And then what happens, and when that happens, we can easily misread competence, intention, or understanding. So recognizing all forms of communication requires a few practical changes, like allowing more time for processing or reducing pressure for immediate verbal responses, or making sure that communication tools are available and consistently respected, because communication is not about just speech, it is about being understood, and we should always keep that in mind. So I know I'm running out of time, but now that we've spent some time on principles, and I know they may sound a little conceptual. So because they show up in every concrete decisions every day, I'd like to shift a little bit to practice. Well, so how do we translate everything that we've discussed, and how do we make this meaningful in our work? We'll go briefly into diagnosis, intervention, and education, but of course we can keep thinking about all of this in our daily life. Because a stance only matters if it changes what we do. So let's start with diagnosis. Here, language really matters. Part of our role is identifying the clinical characteristic required by current criteria, and that won't change. We can still keep DSM criteria or CIE criteria or anything that you prefer. But how we talk about what we see is what matters, especially when we use the words symptom, for example. In medicine, a symptom usually implies pathology, but in autism, of course, there can be symptoms, but many of the traits we describe are better understood as neurodevelopment characteristics, sensory sensitivity, a direct communication style, a focused interest. These can create challenges in certain contexts, but they are not automatically signs of disease. And that distinction is important because it changes the tone of the diagnosis. We can acknowledge support needs without framing the person's identity as something disordered. Diagnosis should also look beyond difficulties. It should include strengths, and it should consider quality of life. What helps this person regulate? What increases participation? What supports well-being? Families are also very, very important in this process. Diagnosis is not something we simply deliver. It's something we build with them through shared understanding. Of course, early diagnosis matters because it opens access to supports, to accommodations, to informed decisions. And we also need to consider masking. Some individuals adapt in ways that reduce visible differences, that can delay identification, and it can make assessment more complex. So naming masking helps us understand why someone may look very different across settings. And it helps us recognize that, again, the long-term cost of constantly having to adapt. So a neuroaffirming diagnostic process still answers the clinical question, but it does so with more context, with more precision, and with more respect for the person. As for intervention, here's where the principles become visible in action. A person and family-centered, strength-based approach starts by looking at what is already present. Not only what needs to be developed, but what is already working. Of course, it doesn't mean ignoring difficulty. We need to recognize the capacity and we need to build from there instead of starting only from what is missing. Intervention also requires some critical reflection on our traditional practices, and I know this is not easy. Not everything that has been done for decades need to be discarded, of course, but everything does deserve to be examined. We can ask simple questions like, what is the purpose of this strategy? What outcome are we prioritizing? What might be the long-term emotional impact of what I'm doing? Affirming neurodiversity often shows up in small decisions, in whether different communication styles are accepted, in whether sensory regulation is supported rather than suppressed, in whether individuality is accommodated instead of corrected. So, also seeking support, it reminds us of the importance that intervention is not only about teaching skills, it's also about ensuring access to resources, to accommodations, to community. Let's keep thinking about removing barriers and not changing the person. If we move to education, we know that most educational systems were designed decades ago. In many cases, they were built around standardization or efficiency or comparison. And I'm sorry to say that structure has not changed at the same pace as our understanding of neurodevelopment. And certainly not at the pace of the social and cultural changes that we are living through. So adapting education is not just a small adjustment. It often requires revisiting some basic assumptions about what learning is supposed to look like. Thriving in schools is not only about academic performance, it is also about emotional safety, regulation, participation, and identity development. I think adapting systems means asking whether classroom expectations are flexible enough to accommodate differences in attention, communication, and sensory processing. But it also means recognizing that learning is relational. Students learn academic content, but they also learn something else, how difference is treated. Classrooms can either reinforce the idea that normality is the standard, or they can model respect for variation. Professional development becomes essential in this context, of course. Teachers were trained within particular frameworks, and those frameworks deserve to be revisited as knowledge evolves. So updating practice is not an admission of failure. It's more a natural response to learning more. We started today talking about the myth of normality, the idea that there is a standard way to think, to communicate, to behave, and that our job is to move people closer to that standard. The more time I've spent in this field, I come to realize that normal is often just what is statistically common. It is not a moral category. It is not a measure of worth. It is certainly not a universal template for a good life. So when we begin to question the myth of normality, we are not lowering expectations. We are refining them. We are asking whether our goals are helping someone build a life that fits for them, or simply helping them resemble something that feels familiar to us. That kind of reflection is not something that we do once. It is ongoing, and honestly, none of us do it alone. That is one of the reasons I value spaces like Autism across different hubs, countries, and focus areas. These sessions create opportunities to examine real cases, to hear lived experiences, and reflect together how we can approach support. Not because anyone was wrong, but because practice evolves when we remain open to learning. The myth of normality is really, really powerful. It is embedded in systems, in training programs, in professional culture. But every time we pause, reflect, and adjust our perspective, we begin to loosen its grip. And that is where meaningful changes begin. Now, I'm just ending my presentation. I'm sorry I took a few more minutes. Just one brief note about the references. Neuroaffirming practice is still an emerging field, so the literature is growing, but it is very much still developing. So it's important to continue research. We need researchers, we need clinicians, we need educators and autistic scholars contributing from different disciplines and different parts of the world. And I am sharing a few resources here with you, but you can always go back to the Autism website where you will find many other resources that you will want to apply to your practice or the ones you serve. And before we close, I want to sincerely thank the organizers and the entire team behind this event. Again, it is a privilege to be part of spaces like this, and creating room for professionals to question their own assumptions is not a small thing. I think it requires courage. I think it matters way more than we sometimes realize. And if there's one idea I hope stays with you today, is this: normality is a moving target, but dignity is not. So the way we define progress, the way we describe difference, and the way we hold power in the room, those are choices that shape real lives. Questioning normality is not about removing standards. It's about making sure that the standards we uphold actually serve the people in front of us. We may not be able to redesign entire systems overnight, but every interaction gives us an opportunity to adjust our lens. And sometimes that small shift is enough to change the direction of someone's life. Thank you so much for being part of this conversation, and I hope we keep learning from each other.
Ramiro, amazing. Thank you so much for sharing that. And I hope for those that are listening who maybe don't know a whole lot about neurodiversity or neuroaffirming practice that they learned something new. I know I did. And I love that eye towards dignity and that eye towards really thinking about how do we keep that front and center in the works that we do. And so thank you so much for that. We do have a couple of really awesome questions that I want to make sure we get to. And so let me, again, kind of pull those over so I can we're managing all the things over here. So I have a great question coming in about, do you have advice for when a clinician is working with a preschool age child, for example, and their caregiver's goals or wishes are not neuroaffirming? And I'll just speak to this a little bit further. I see this a lot, right? Where it's like, no, they need to do this or that or whatever. And so help us understand that, or what's some advice when working with that type of situation?
I think that the best advice I can give, and again, these are not rigid rules, and of course, we should always be mindful of each case in particular, but it's to ask these questions. What are we planning this for? Who is this serving? Is this something that we want to avoid because it's not common for other people, or is this something we want to avoid because there's actual risk for the person? Some behaviors might be challenging for people and even cause harm, and of course we want to change those behaviors. But flapping hands, for instance, who does flapping hands hurt? I think those are the questions that we need to be mindful of, and once we start asking them, I think everything becomes more visible, because when someone answers, so I want to change this, or I want to work on this or that goal, it shows the paradigm behind all of that. So I think it's a beautiful way of making the person notice their own biases, and of course we can always provide resources and share information and try to make those people understand why lived experience is so important.
Excellent. Thank you. And so, one of our listeners has asked that, many of our assessment reports, and she's explaining that her assessment reports are often based in how we were trained. So that very deficit-based, symptom focused, kind of reporting. And so she's asking if you have suggestions or different ways of describing that still within a diagnostic. I'm going to use diagnostic at the moment, but it could technically be other kinds of reports. Do you have any suggestions for how we can do that while maintaining kind of, I guess, the professional expectations?
Absolutely. I can also share a talk I've given some time ago about neuroaffirming evaluation and assessments. It's in Spanish, but I'm sure you can use a translator for that. But I think the most important thing is to recognize strengths. I mean, we are still doing reports, we are still conducting assessments. That won't change. What will change is the way we read those results. So instead of saying this person doesn't look other people in the eye, we can say the style of communication for this person is different than the majority for this, and that. But we need to acknowledge that this person communicates. It may not look like other people communicating, but they are still communicating. So that is the shift in the way we think. We are not talking about deficits. We are talking about concrete situations, not adding an extra layer of judgment, which is what we typically do without even noticing. Again, I'm not blaming anyone. I was training these systems. I know many of us have. So we just have to change our brain chip to think about these things from a different angle and from a strength-based perspective.
Excellent. Yep, agreed. It's something that I actually have to work on a lot when I'm thinking about my own reports and trying to think about how I describe behavior. It's amazing where bias can creep in. And it's funny because when I have trainees with me, so residents or fellows or what have you, um, I just call it out. I'll be like, "Oh, my bias is affecting what I'm doing," and lots of different types of things that kind of filter in there. And so I like to call it out so that people can watch it in me so that they can see it in themselves. But even as I'm describing behaviors, I have to remind myself, no, 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 wait a minute. What do you see? Not necessarily like what is not right, so to speak. Because again, I'm a physician and this is like bred in us to see what see what's wrong and fix it, as I like to tease tease people. And so it's definitely it takes effort daily, frankly, to adjust those habits for even for those of us who have been doing this for a while. So one of the questions that I wanted to ask you that's come in from one of our participants is, as an autistic employee, so this person's an autistic employee, what are the best ways to help an employer understand the need for some of these differences, especially things like flexible seating, fidgets, or things that aren't major accommodations?
That's a great question, and I'm really glad that there are autistic employers, and that there should be more because they bring so much to the work environment, and it's amazing to count on different ways I mean, on different minds and different skills, and please go for it. I think that the best alternative here is to ask the person. I mean, if the person cannot express it or they have challenges, ask their family or their loved ones or their service providers. I think there's one important word, and we use it all the time on eco-autism programs. It's co-production, and I think it applies to everything, or it should apply to everything in the daily life of an autistic person. We cannot use a manual for these kinds of things because each individual is different. So all the approaches should be different. So, but it's really important that you are considering adjusting things and giving support for those people. Again, I would say it's a case by case and person by person. So ask them and try to come with a plan together.
Excellent. And I'll just add to that because in one of the other questions is a little bit similar. In essentially, how do we, I think especially for those of us in healthcare, we are often thinking about people through the lens of patients, for example. And this person's comment and kind of question is, how do we zoom that out a little bit so that we can see our colleague as somebody who may be neurodivergent or have differences in the way that their brain functions? And so the question about how do we help employers understand or accept, acknowledge, include fidgets or seating differences, things like that. I think that frankly, it's about asking. So what I would encourage us to think about is what are ways that we can educate our employers, if you will, about all of these different diverse needs. I think that's really important. But then I also would say autistic people figuring out how to help them learn to find that voice and to express again, whether that's whatever form of communication that comes in. Hey, I need this, right? This helps me do my job better, and I want to do my job well. This is what I need to be able to do that. And so, again, I do think that takes that frame shift, though, because oftentimes employers are like, you want to what? Right? You want to sit backwards in a chair and wiggle your toes. And sometimes, unfortunately, in our society, that's super frowned upon. And yet, why, right? And so, again, how do we think about that? And how do we think about that in different ways? I'm going to wrap up with one more question. And it's around this idea of exploring and increasing research into neuroaffirming practices. And so, you mentioned that more research is needed. And so, as you reviewed the literature, as you think about this, the scope of what's out there, where do you think the biggest gaps are? And so, as clinical researchers, who want to contribute to this field, where can they add the most value?
Honestly, everywhere. I mean, autistic voices are really important because, again, it helps us remove our biases, or at least making them clear. I think much more research is needed in terms of lived experience itself, and it's a whole topic. But we've recently started seeing trauma in autistic adults, and that's something we had never focused in the past, or minimally focused in the past. The lived experience, the needs that autistic population has, those should be the goals, and not so much what we think. I mean, we as neurotypical, assuming I am, but not so much what we decide to focus on, or what we want to explore through research, but more about what they need. I think that should be the best alternative. And of course, we need to open to different alternatives, and sometimes hear things that we may not like, but that are really, really necessary.
Excellent. Well, again, thank you so much for sharing your expertise, helping us to think differently and more broadly about the world that we live in. Certainly, I've always appreciated and continue to grow in my understanding of this topic, especially with your guidance. And so thank you for that. We're going to go